Welcome to Metacoccus video series, where we explore frequently tested concepts in USMLE and NBME exams. In this video, we are continuing our discussion on the recently tested USMLE renal topics, breaking down essential cases to help you prepare effectively. We begin with a 47-year-old woman who presents with symptoms of fever, dysuria, and abdominal pain. She mentions a long history of recurrent urinary tract infections, beginning in her teenage years. A physical examination reveals mild suprapubic discomfort, and a urinalysis shows pyuria and bacteriuria, confirming the presence of an active infection. A CT scan of the abdomen is performed, revealing a fusion of the kidneys at the lower poles consistent with a horseshoe kidney. In this case, what anatomical structure is responsible for limiting the normal ascent of this fused kidney during embryological development? The correct answer is the inferior mesenteric artery. Horseshoe kidney occurs when the kidneys fuse at their lower poles during development, forming a U shape. The fused portion, or isthmus, becomes trapped under the inferior mesenteric artery during ascent, preventing the kidneys from reaching their normal position. Most are localized at the level of the 3rd to 5th lumbar vertebrae, often around the 4th lumbar vertebra, due to the obstruction caused by the inferior mesenteric artery. It may be asked in exams at which level this occurs, and the answer will likely be the 4th lumbar vertebra. This low position increases the risk for complications such as hydronephrosis, UTIs, and nephrolithiasis. While horseshoe kidney is often asymptomatic, the abnormal anatomy increases the risk of ureteropelvic junction obstruction, urinary stasis, recurrent infections, and nephrolithiasis. This explains why the patient in this case has experienced multiple urinary tract infections throughout her life, as the structural abnormality predisposes her to incomplete emptying of the bladder and stagnant urine, which promotes bacterial growth. In addition to UTIs, patients with horseshoe kidney may also be prone to other complications such as hydronephrosis, which is due to obstruction of urine flow, 𝐊𝗠liTe, flank pain, and hematuria. It's important to note that horseshoe kidney can also be associated with certain chromosomal abnormalities, including Turner syndrome and trisomy 18, although many cases occur in otherwise healthy individuals. Before we move further, it's important to understand that kidneys develop from the metanephros, which includes the metanephric blastema, precursor to the renal parenchyma, and the ureteric bud, which forms the renal collecting system. In patients with horseshoe kidney, the metanephric blastema fails to separate properly, leading to the fusion of the kidneys at the lower poles. As the kidneys attempt to ascend during development, they become blocked by inferior mesenteric artery, leading to their characteristic low position in the abdomen. Management of horseshoe kidney focuses on addressing complications as they arise. While no specific treatment is required for the anatomical anomaly itself, it's important to manage conditions such as hydronephrosis, UTIs, and nephrolithiasis if they occur. Patients may require antibiotics for recurrent infections and, in some cases, surgical intervention to correct any obstructive issues at the ureteropelvic junction. To summarize, horseshoe kidney is a congenital condition in which the kidneys fuse at their lower poles and are unable to ascend to their normal position in the abdomen due to the presence of the inferior mesenteric artery. While often asymptomatic, this condition increases the risk for urinary tract infections, nephrolithiasis, and hydronephrosis due to abnormal urine flow. Diagnosis is typically made through imaging studies such as CT scans, and management focuses on treating associated complications. All right, another frequently tested concept here, polycystic kidney disease. Let's first quickly break down the key differences between autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease. Autosomal recessive PKD typically presents in infancy or prenatally and can lead to complications like oligohydramnios, Potter sequence, and pulmonary hypoplasia, which is a critical complication. In contrast, Autosomal dominant PKD often shows up later in life and is associated with cerebral aneurysms and liver cysts. It's rarely diagnosed in newborns. Early diagnosis, especially in autosomal recessive PKD, requires prenatal ultrasound, and the management generally focuses on supportive care to manage these complications. Let's move into our first PKD case, a 54-year-old man who presents with blood in his urine and abdominal discomfort. 2 days ago, while moving potted plants, he began experiencing abdominal pain, which was followed by blood in his urine. The bleeding resolved the next day. He has a history of hypertension but does not use tobacco, alcohol, or illicit drugs. His physical examination shows no abnormalities, and a CT scan reveals the presence of multiple renal and hepatic cysts. The most likely diagnosis here is autosomal dominant polycystic kidney disease. This is a genetic disorder caused by mutations in the PKD1 or PKD2 genes that lead to cystic enlargement of the kidneys. Patients often remain asymptomatic until their 4th or 5th decade of life, but they may experience symptoms like flank pain, hematuria, and hypertension. The key diagnostic finding here is multiple non-enhancing cysts on imaging, which are typically smooth-walled. Other important manifestations include liver cysts and cerebral aneurysms. Next, a 56-year-old man with a history of autosomal dominant polycystic kidney disease who presents to the emergency room with a sudden onset severe headache. He has never experienced a headache like this before, and his examination reveals some neutral rigidity, but no focal neurological deficits. This case is highly suggestive of a subarachnoid hemorrhage, which is a serious complication of autosomal dominant PKD due to the rupture of intracranial berry aneurysms. These aneurysms often arise in the circle of Willis and May rupture, causing the sudden onset of a thunderclap headache. CT imaging of the brain is the preferred initial diagnostic tool, and if the scan is negative but clinical suspicion remains high, a lumbar puncture should be performed to check for xanthochromia. This is a high-yield point to remember for exams. Next, let's look at a 33-year-old man who presents with left flank pain and a history of hypertension. A renal ultrasound shows multiple cysts in both kidneys, along with echogenic foci suggestive of nephrolithiasis. His father passed away at age 42, raising suspicion for an inherited condition. This case highlights autosomal dominant polycystic kidney disease, a genetic disorder that increases the risk of intracranial bleeding due to cerebral aneurysms. These aneurysms become more prevalent with age and are a significant cause of mortality in patients with autosomal dominant PKD. Hypertension, which is commonly seen in this disease, results from increased renin secretion due to renal ischemia. This is a crucial point to remember when managing patients with autosomal dominant PKD. Autosomal dominant polycystic kidney disease, as mentioned earlier, manifests later in life, typically between the ages of 30 and 50, with symptoms such as flank pain, hematuria, and hypertension. In contrast to autosomal recessive polycystic kidney disease, which presents at birth, autosomal dominant PKD is often clinically silent in newborns because the cysts are too small to be detected by ultrasound. This is an important distinction to keep in mind for the exam. Let's now shift to a case of a 51-year-old man who presents with nausea, fatigue, and a history of bilateral flank pain and nocturia. His physical exam reveals an enlarged liver and a palpable mass in the right flank. His lab results show elevated serum creatinine and blood urea nitrogen levels, indicating chronic kidney disease. This patient likely has advanced autosomal dominant PKD, which can lead to progressive renal failure. The patient's hypertension, polyuria, and nocturia result from cystic damage to the kidneys, while the liver enlargement is due to associated liver cysts, a common extrarenal manifestation of autosomal dominant PKD. Progression to end-stage renal disease typically occurs by age 55 to 60 in patients with autosomal dominant PKD, making early recognition and management critical. In our final case for autosomal dominant PKD, we have a 35-year-old woman who presents with blood in her urine after working in her garden. She has a history of recurrent flank discomfort, but no dysuria or urinary frequency. Her father passed away from kidney disease at age 40. On examination, her blood pressure is elevated at 180/120 millimeters of mercury, and laboratory results reveal hematuria with elevated serum creatinine. This is another case of autosomal dominant polycystic kidney disease. Recurrent flank pain and hematuria in these patients often result from cyst rupture, which can be triggered by physical activities. The high blood pressure seen here is an early sign of autosomal dominant polycystic kidney disease due to increased renin secretion from ischemic kidneys. As the disease progresses, patients may develop chronic kidney disease leading to renal failure. Early intervention is key to managing the complications of this condition. Next, we have here a posterior urethral valves case. A 1-week-old boy who's been admitted to the hospital due to urosepsis. He's currently receiving antibiotics. The boy was born at term via spontaneous vaginal delivery, but unfortunately, his mother received no prenatal care. On physical examination, the patient has lower abdominal distension, and a renal ultrasound reveals a thickened bladder wall with bilateral vesicoureteral reflux and hydronephrosis. In this case, the boy is most likely suffering from posterior urethral valves. This condition is caused by a persistent urogenital membrane, which results in bladder outlet obstruction. This obstruction leads to bladder distension, hypertrophy of the bladder wall, and vesicoureteral reflux, all of which are seen on his imaging. The reflux of urine back into the kidneys causes hydronephrosis, which increases his risk for recurrent infections like urosepsis. The clinical signs and ultrasound findings are classic for bladder outlet obstruction, and this can be a critical condition if left untreated. The pressure within the bladder and urinary system can damage the kidneys over time, leading to long-term complications such as chronic kidney disease. Our next case is an infant who was born at 39 weeks but unfortunately passed away within an hour due to respiratory failure. He presented with tachypnea, hypoxia, flattened facial features, and clubbed feet. His breath sounds were diminished bilaterally, and despite being intubated, his oxygen levels did not improve. The autopsy revealed bilateral renal agenesis, which led to Potter sequence. This condition occurs when a urinary tract anomaly, such as bilateral renal agenesis, leads to decreased fetal urine output. Since fetal urine is a major component of amniotic fluid, the lack of urine results in oligohydramnios, or low amniotic fluid levels. The absence of this fluid causes compression of the fetus, leading to flattened facial features, a characteristic Potter facies, and limb deformities like clubfoot. However, the most critical consequence of oligohydramnios is pulmonary hypoplasia. The developing lungs do not have the necessary amniotic fluid to expand and grow properly, leading to respiratory failure at birth, which is often fatal. In this case, the lack of prenatal care likely delayed the diagnosis, as prenatal ultrasounds can often detect the signs of Potter sequence, such as oligohydramnios and absent kidneys. The take-home point is that Potter sequence is a life-threatening condition, and pulmonary hypoplasia is the most common cause of death in affected infants. Now let's look at another case. A 24-year-old woman is undergoing a routine prenatal ultrasound at 19 weeks gestation. The ultrasound reveals a male fetus with bilaterally enlarged kidneys, which contain diffuse small cysts. The amniotic fluid volume is very low, and no other anomalies are observed. This fetus most likely has autosomal recessive polycystic kidney disease, a genetic disorder caused by mutations in the fibrocystin gene. This condition leads to the formation of numerous small cysts within the kidneys, impairing their ability to function properly. As a result, the fetus produces little to no urine, leading to oligohydramnios. This oligohydramnios places the fetus at risk for Potter sequence, just as we discussed in the previous case. The flattened facial features, limb deformities, and pulmonary hypoplasia are characteristic of this condition. After birth, these infants often present with respiratory distress, which can be life-threatening due to the underdeveloped lungs. Children who survive the neonatal period are at risk for developing chronic kidney disease and require lifelong management. These patients may eventually need kidney transplantation or dialysis. It's important to note that while autosomal recessive PKD can be detected during prenatal screenings, the severity of the condition varies, and some infants may survive into adulthood with proper treatment. Okay guys, now let's dive right into Fanconi syndrome, a condition affecting the proximal convoluted tubule of the kidney. This syndrome results in various clinical features such as failure to thrive, polyuria, muscle weakness, and electrolyte imbalances. All of these are caused by the impaired reabsorption of essential substances in the proximal tubule. We start with a case involving a 6-year-old boy who presents with poor weight gain, frequent urination, and muscle weakness. His parents report that he has been more tired than usual and has been urinating excessively for several months. On examination, the boy shows signs of mild dehydration, and laboratory tests reveal hypokalemia, hyponatremia, hypocalcemia, and hypophosphatemia. Urinalysis demonstrates proteinuria, glucosuria, and aminoaciduria despite normal serum glucose levels. These findings are characteristic of Fanconi syndrome, a disorder where the proximal convoluted tubule of the kidney is unable to properly reabsorb substances like glucose, electrolytes, and small proteins. This leads to their excessive loss in urine, causing the electrolyte imbalances observed. The glucosuria with normal serum glucose levels is a key indicator of proximal tubular dysfunction because the regulation of blood glucose is independent of kidney reabsorption. The electrolyte disturbances, like low potassium and phosphate, result from the impaired reabsorption of these solutes in the proximal convoluted tubule. Damage to the proximal convoluted tubule also leads to the urinary loss of amino acids and proteins, contributing to failure to thrive and muscle weakness. In our second case, a 7-month-old girl is brought to the office due to poor weight gain and frequent wet diapers. Her weight percentile has dropped from the 50th to the 3rd percentile, and on examination, her wrists appear widened, suggesting rickets. Laboratory tests reveal hypophosphatemia, hypokalemia, and a normal anion gap metabolic acidosis. This pattern is typical of type 2 renal tubular acidosis, a condition that can occur as part of Fanconi syndrome. In this case, the damage to the proximal tubule leads to the loss of bicarbonate, causing metabolic acidosis. The low levels of serum phosphate contribute to the development of rickets, as phosphate is critical for bone mineralization. The hypokalemia contributes to her muscle weakness. Importantly, the increase in serum chloride is a compensatory mechanism that maintains the body's electronegative balance in the face of bicarbonate loss. Despite the glucosuria, the serum glucose level remains normal, as glucose regulation is managed independently of kidney function. Next, we have a 2-year-old boy who presents with failure to thrive and frequent urination. His weight has fallen from the 60th percentile to the 10th percentile over 6 months. He has glucosuria on urinalysis, though his serum glucose is normal. Additional laboratory tests reveal hypophosphatemia, hypokalemia, and a normal anion gap metabolic acidosis. The findings in this case are consistent with Fanconi syndrome, where the proximal convoluted tubule fails to reabsorb critical substances, including glucose, phosphate, and bicarbonate. The persistent acidosis results from the inability to reabsorb bicarbonate, and the hypophosphatemia causes bone deformities such as frontal bossing and rickets. The glucosuria and polyuria are due to impaired glucose reabsorption and an overall reduction in the kidney's concentrating ability. As with other cases, despite the urinary glucose loss, the serum glucose remains normal due to other compensatory mechanisms in the body, such as insulin and glucagon regulation. To summarize, Fanconi syndrome is a disorder of the proximal convoluted tubule that leads to the urinary loss of substances normally reabsorbed by this part of the kidney, including glucose, electrolytes, amino acids, and bicarbonate. This results in clinical features such as failure to thrive, glucosuria with normal serum glucose, polyuria, hypophosphatemia, hypokalemia, and a normal anion gap metabolic acidosis. Early recognition of this pattern is crucial for diagnosis and management. That's all in this video. Please make sure to review these key points for your exams and stay tuned for more high-yield nephrology cases. Thank you for joining this episode of the Metacoccus video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.